This is chapter 13 in your book. So as we talk about fluids here, right, we're going to talk about the composition of the body, right? So about half of our body, total body, is made up of water, right? So water is important, right? What is the difference between an older adult and an infant? Why does that come into play here when we talk about fluids and electrolytes? What do you know about infants?
They're mostly
Look at that
water.
picture there.
Mostly water.
Mhm. They're mostly water, right? 75% made up of water. Are they at risk for dehydration?
Yes.
Yes. Okay, can easily lose body fluid. Because think about, if anybody's ever had children, been around children, what kind of illnesses do they get? They get everything. GI illnesses, right? Nausea, vomiting, diarrhea, colds, fevers, right? I feel like if you have a child, they're always sick, like the first 5 years of their life, right? They've always got something, right? So at risk for fluid imbalances. What about the older adult?
They have less
Less,
fluids.
yep, so less fluid, a body weight. Yeah, what else do they have? They have less subcutaneous tissue, or they have more subcutaneous tissue, less muscle. What do you know about muscle, subcutaneous tissue, fat tissue, and water? Men are 60% versus female, 55%. What is the difference there?
Muscle.
Men tend to have more muscle. Does muscle hold on to water? What about fat? Okay, as we get older, we tend to have less muscle, more subcutaneous tissue. Okay. What else about the older adult when it comes to fluids?
I don't really drink.
Yeah, why? What are the reasons why they maybe not want to drink as much? They have no desire. That thirst drive can decrease, right? Because our body tells us you're thirsty, you need to drink, right? As we get older, you may not have that. Why else are older adults at risk for fluid and electrolyte imbalances? Yeah, mentation, cognitive, right? They may forget to drink. Anybody work in long-term care? Do you guys go around with beverage carts, or they still do the little beverage cart? Well, here's your little afternoon drink, right? Have a drink. Might have to remind them to drink. What else? Yeah, medications. What kind of medications are older adults on? Bumps. Okay, anything that could influence fluid and electrolytes. Diuretics is a big one, right? Clients might be on diuretics to decrease their blood pressure. Okay. So differences there. We talked about age, we talked about gender, right? With having to do with the muscle and the subcutaneous tissue. Okay. So two main components. We've got the intracellular, right, inside the cell. Okay. That's about 2/3 of your body fluid is inside the cell. And then the extracellular fluid is outside of the cell, right? And that's about 1/3 of your body water, total body water. Okay. And that includes like the plasma, the interstitial, which is that fluid between the cells. Okay. It can also include like the transcellular book talked about, like your CSF, your peritoneal fluid, pleural fluid, right? All those extra fluids that are outside of the cell. All right, good. So let's think about fluid balance. As a nurse, is it important for you to think about fluid balance?
Yes.
Have you done I's and O's on your clients that you've cared for?
Yes.
Why are you doing them?
See if
Because
they
the doctor ordered them, so I just do what the doctor tells me to.
make sure they're not in fluid deficit
They're not in deficit or
or
overload,
overload.
right? So what should go in should come out, right? Sometimes you want more to come out, right? Depending on the patient, right? So thinking about intake, right? Thirst regulates our fluid intake. Okay? When our blood volume is low, okay, does the body say you need more fluid? Need to drink. Okay. What about if our blood osmolarity is high? What is that telling me? When you think of the word blood osmolarity, what is that telling you? What do you think of? Dehydration. Yep. So all those extra particles, right? So we think about osmolarity, that's those particles that solute that's left, right? Okay, if I have a high blood osmolarity, I have more particles than I do water, so I need to drink. Okay? About 2,000 to 3,000 milliliters per day is an average that people would take in. Okay? That's probably my intake of Diet Coke a day, right? Probably not water, right? I should do better about water. But that's about what should go in, okay? How do we take in oral, or how do we take in fluids? We've got oral, right?
IV.
IV we could take in. Anything else that a patient could get? Anything, NG, yeah, G tube feeds, NG tube feeds, anything like that, where they could get fluids, they could get feedings, okay? What about output?
Urine.
Urine, yeah, that's a big one, right? Urine, okay? How else do we lose fluid? Sweating, vomiting, diarrhea, okay, wound drainage, right? Breathing, perspiration. Are we able to measure all of that?
No.
So we talk about insensible fluid loss, right? That's what we can't measure. Our breathing, our sweating. Right? We're not gonna be able to measure that. But at clinical, when you care for patients, you're measuring output, urine output, okay? You're measuring liquid stool, okay, any vomit. So isonos are important. We need to keep track of what's going in. Is it coming out? Is there an overload? Is there an underload? Okay. You guys had a worksheet for this week. Conversion. Some of you need to work on your conversions. Okay. Isonos. So if I have 1 ounce is how many milliliters?
30.
30. Okay. 1 cup
8 ounces.
is how many ounces?
Eight.
8 ounces, or how many milliliters?
240.
240, okay? 1 teaspoon is how many milliliters?
5.
5. 1 tablespoon,
15.
15, okay? So no decimals, right? Everything will be a whole number. So again, make sure you know those conversions. You might see another question like that. Maybe. Be a great math question, wouldn't it? For the test? No. Okay, so making sure that you know your conversion so that you're accurately being able to know balances. Are there some people that you have to do very strict isonos?
Yes.
Okay, your heart failure patients, you can't overload them, right? You could kill them if you give them too much fluid. Okay, so it's really important that you know how to accurately do your intake and your output. All right. Hormones. Hormones are a big part of this too that I want to talk about. Okay, so we are going to talk about antidiuretic hormone, the renin-angiotensin-aldosterone mechanism or system, and natriuretic peptides. Okay, those are kind of things that I want you to understand too as we're going through. We're going to talk about this again when we get into endocrine, when we talk about cardiac. These same type of hormones are going to be involved. Okay, so antidiuretic hormone. What does that mean to you? What is a diuretic? The patient takes a diuretic, what is that supposed to do? Make him get rid of extra fluid. So what's an antidiuretic?
Retain
Yeah,
water.
it's holding on to water. Good. Okay, so this is kind of a good way to think about it. Remember, antidiuretic hormone is made in the hypothalamus. It's stored and released by the posterior pituitary gland. Okay, so if you have an heavy intake of salt or increased sweating, okay, take in too much salt, right? You go into McDonald's, you take a whole bunch of food, you're out sweating and you lose fluid, okay? So what's happening? I have all this extra salt. What's happening to my blood osmolarity? It's going up, right? I have all this extra particles, this salt, okay? So I have more salt, more particles, and less water. So what does the posterior pituitary gland do?
Release
It's gonna release antidiuretic hormone. Okay, what is that gonna do? Hold on to water, right? It's gonna reabsorb that water from the kidneys back into the body. Okay? A little bit was gonna go into the bladder and gonna go into the urine, right? Because we still need to get rid of toxins, right? We still need to get rid of those. So we're gonna have more water, more volume of blood water into our blood volume. Okay, because what does the body want? What's homeostasis, right? It wants everything to be how it should be. Okay, okay, let's look on the opposite end here then. We take in too much water. Can you take in too much water?
Yes.
You can go into water intoxication, right? So I take too much water. I have a high water concentrate in my blood. What happens to my blood osmolarity if I take in too much water?
Low.
It's gonna go low, right? I have more water than particles. Okay, so the pituitary gland goes, oh, all right, I need to release less of this. Okay, so it's not gonna reabsorb as much water. And how are we gonna get rid of that extra water? Urine, right? It's gonna go to the kidneys. The kidneys are gonna get rid of that. We're gonna urinate that out, again, to make sure that we have a normal balance. That makes sense? Right, so really understanding that, because we'll talk about that again and again this term. All right, let's talk about the renin-angiotensin aldosterone system, the RAS system here. Okay. When does the kidneys release renin? When does this system, what do you want to call it, mechanism happen? Why does the kidneys release renin? Yeah. When our blood volume is low, when our blood pressure, therefore our blood pressure would be low, right? If we have less volume, we're gonna have less blood pressure. Yep. Okay. When our blood osmolarity, right? Low. So renin is gonna activate, or the liver is gonna release angiotensinogen, okay? Then we have angiotensin 1. Is that an active form? Does that do anything? No, okay. So now we need to have ACE. The lungs are going to release ACE. What does ACE stand for? Thank you. Angiotensin converting enzyme. So that is going to make angiotensin 1 convert into angiotensin 2. Is angiotensin 2 the active form?
Yes.
And then what is that going to do? Vasoconstriction. When we have vasoconstriction, what happens to our blood pressure? It increases. Is that what we want to do? Is that why this system is going on?
Yes.
Right? We have less blood volume, we have low blood pressure. Angiotensin 2 causes vasoconstriction. Okay? Then it also is going to cause the adrenal glands. Where do the adrenal glands sit? Where are they located? Top of the kidneys. Okay? Adrenal glands are going to release aldosterone. Okay? An important hormone that we're going to talk about again and again. Okay? What is aldosterone going to do then? Yep, we're going to hold on to sodium. And where sodium goes, what follows? Water. So now I have sodium, I have water. What's happening to my blood pressure?
Going up.
We're going to hold on to sodium. We're going to hold on to water. What else is aldosterone then going to release? Potassium. Okay, so it's going to release potassium. All right. Turn to your partner. Explain antidiuretic, the hormone, and how it works. Go. What
I
does
don't
that
have a
hormone
partner.
do?
I'll combine.
Why is it secreted? When is it secreted? What is its role? Okay, now explain to your partner. Renin-angiotensin aldosterone system. Secrete aldosterone, what does aldosterone do? Hold on to sodium and water. Get rid of
Potassium,
angiotensin two causes.
vasoconstriction.
All right, good. All right, what about BNP? Okay, now we're gonna talk about some of our natriuretic peptides. Okay? So these are hormones secreted by the cells that line the heart, the atria and the ventricle. Okay? When are these secreted? When are these peptides secreted? Volume overload, yes. When there is a stretch of the heart, when the blood volume is too high, okay? The blood pressure is too high, there is a stretch, okay? So the atria releases, atrial natriuretic peptides. The ventricles of the heart, the bottom of the heart, actually releases BNP, which stands for brain natriuretic peptides, even though it's from the heart. Okay, it was first found in the brain, but it has to do with the heart. Okay, so there's a stretching, there's an overload. Those peptides are released. And what should happen? How do the actions work here? Natriuresis, diuresis. What do those mean? Natriuresis is what? Get rid of what? Sodium, yeah, and diuresis. Get rid of fluids, right? Okay, so we're getting rid of the extra fluid and water, which hopefully will then decrease our blood pressure. Okay. All right, so it's going to work kind of the opposite of aldosterone, right? Okay. Going to inhibit the reabsorption of sodium. Okay, we want urine output. We want less blood volume. Okay. So when you are out in clinical and you are caring for clients who come in with fluid overload, you will see that they often will draw a BNP. Okay. This is one of a lab diagnostic test that might help you figure out, does this client have fluid overload? Does this client have heart failure? Right? Because over time, is the body going to respond like it should if there is an increase of the peptides of BNP? Right? Over time, it might not. There might be so much fluid, the heart might not be working like it will. So we'll do a BNP. Brain natriuretic peptide. It's a big indicator the client has heart failure. Now, it can also show you if a client has a PE. Sometimes it can be elevated if the client has a PE. If they have kidney failure, because the kidneys filter that. Okay, hypertension can sometimes cause this, but usually it's a big indicator of heart failure. Okay, so anything less than 100 is normal. Right? If a patient comes in with a BNP about 300 or so, they're in mild heart failure. Moderate is 600, severe is 900 plus. It might be 10, 12, 15, 20,000, right? It can be quite high. The patient is in severe heart failure. Okay. You are going to see a lot of patients in clinical who are in heart failure, who come in with exacerbations of heart failure. Pretty common, fluid overloaded. Okay. So another diagnostic test to look what else is going on with that client, right? Other assessment data you might have to collect. All right. So as we talk about fluids and electrolytes, who is at risk for any type of fluid and electrolyte imbalance? Yeah, elderly and infants, absolutely. It's a big one. Okay. Who else is at risk for fluid and electrolyte imbalances? Athletes, okay. Like you sweating a lot, using that electrolytes that way. Who else? Yep, children, yep, adolescents. Are you at risk for fluid allergy and allergy? Anybody ever had the stomach flu?
Mhm.
Anybody party too hard the night before? Woke up a little dehydrated? Are you at risk for fluid allergy imbalances? How about people in the hospital? Are they at risk? How about elderly that get, I'm talking about elderly, right? Cognitive changes. Are we all at risk? Yes. Okay. Prevention is a key, right? We can most often prevent a lot of our fluid electrolyte imbalances with teaching, right? Especially if a client has what? Heart failure, right? Any kidney disorders, right? Doing good client education, okay? What do you teach yourself? What do you know about if you get dehydrated, if you have the stomach flu, if you're vomiting, if you have diarrhea?
Drink water.
Drink water.
Try to drink, right? Drink water, drink oral replacement fluids like Pedialyte. Okay? Teaching that. Dietary measures. Okay. We'll talk a lot about when in the electrolytes, right? Did you learn a lot about different types of food, what you should eat, what you should not eat? Sodium, calcium, potassium, right? Could that help? Especially with your sodium, right? Could that help with your fluid and electrolyte imbalances? And then fluid management, right? If there's any risk of sweating, right? You're outside working, you're outside exercising, okay? Fluids. Fevers, you need fluids. Diarrhea, you need fluids. Vomiting, right? Are there some people that need to watch their intake though?
Yes.
Right, think about those patients who have heart failure, who have kidney disease, right? They can't filter, chronic kidney. We have to make sure that they have enough fluid so that we don't fluid overload them, okay? Everybody's at risk, okay? When you look at a client who has fluid and electrolyte imbalances, a lot of times they're non-specific. Okay? If a patient came in with nausea, dizzy, muscle cramping, could that be a lot of different things?
Mm-hmm.
Are you automatically thinking, oh, must be sodium, right?
Mm-mm.
Must be potassium? A lot of variety of different things. They can be very non-specific. Okay. Vomiting, diarrhea, I mean, that's pretty specific, right? You know that they're gonna be in a fluid loss. Okay. So there'll be a lot of risk factors. And if they come in with unexplained nausea, vomiting, muscle cramping, edema, what do you think is gonna be ordered to get some more information?
An electrolyte.
Electrolytes, right? We want to look at those electrolytes. What is their sodium? What is their potassium? So a basic metabolic panel, right? Gotta get those electrolytes. Okay. All right. Some other things to think about, right? Fluid electrolyte imbalances can happen in all clients. It doesn't matter their age, their gender, their race. Right? Kind of have to have some underlying information. What kind of things would you look for in a client who was fluid overload? What would you look for a client who's overloaded? Right? Think about children. As we talked about children, right? The infants and the very young children are at risk for fluid imbalances. A lot of times, like I said, they have those GI illnesses. Okay? They have a greater risk for extracellular fluid deficits. Okay? Greater at risk for hypernatremia. So again, you have to assess those clients. We talked about children, right? Do children know that they need to drink? Are they gonna tell you, oh, I'm thirsty, I need to drink, if they're a 1-year-old? Right? No, that's teaching families also, okay? Older adults, we talked about that, right? Decreased thirst, cognitive changes. Physically, they might not be able to drink, to grab a drink, to go to the kitchen and grab something. If you work with the elderly, what else do they maybe not want to drink a lot? Because then they have to do what?
Go to the
They
bathroom.
gotta get up and they gotta go to the bathroom. Is that sometimes a struggle for some clients?
Yes.
Right? They might have some physical limitation. Okay, but explaining some education on that's important. Okay. All right. So when you are thinking about a client, when they have any kind of fluid electrolyte imbalances, daily weights, right? Daily weights are gonna be your best indicator of fluid status. Your heart failure patients are gonna have me on daily weights. Are they gonna track those daily weights? Yes. What do you teach a client about taking their weight?
Take it some time.
Same time,
Before you eat, same food.
same clothes, yep, same scale.
Before you eat.
Usually first thing in the morning, right? Empty your bladder. Get on the scale. Okay? Write it down. Right? Okay. So your weight's gonna be your best indicator. Okay? You might have to do eyes and O's on your client, right? 24-hour eyes and O's, right? Look at what's intake and what's out. Okay? We talked about that. Think about what is considered input. Right? Any foods, some foods are higher in water, drinking fluid, but they take it through an IV. And an output, right? Wounds, gastric suctioning, vomiting, diarrhea, urine, that would all be considered. Okay. Urine output. So it is recommended or needed that clients have at least 30 milliliters out of urine per hour. Okay. Obligatory urine output is 400 to 600 milliliters per day. What does that mean?
You need to have
You
it.
need to have that out to remove all the toxins. That should be minimal. Okay, are all clients gonna have that? Who might not have 400 to 600 a day? Yeah, dialysis patients, right? Those clients that are chronic kidney disease, stage 5, that are on dialysis. Okay, but you should hopefully have 400 to 600. Okay, adults, they kind of say 30 per hour. Sometimes it might be weight based. Okay, so depending on what the patient is in the hospital for, they might look at the weight. Okay. Infants have a little bit more. You don't have to memorize these numbers. Okay, these are just some numbers to think about that you might see in a client. I do want you to know 30 though, 30 an hour. Okay, is recommended the minimal that a client would need out per hour for an adult. Okay. But as if you work with children, it's gonna be a little bit more than we're gonna have for your output. So that's your job, right? That's part of your role is to eyes and outs. Can we, as the nurse, delegate eyes and outs
Yes.
to our UAP that we're working with?
Yes.
Yeah, but ultimately, who's responsible for those numbers? Yeah, the nurses, right? You have to go back and look at those numbers. They're gonna put it in the chart, but you have to know if there's 500 in and 20 milliliters out, you got a problem. Right? All right. So again, this is just a review, right? We talked about regulation of water, right? We talked about antidiuretic hormone. Okay. We talked about the RAS system. Okay, we talked about adrenal glands, aldosterone, and natriuretic peptides. So it's just a review of the content that we just covered. Okay. Those all systems are all interrelated to make sure that the body stays hopefully in a homeostasis. Okay. So again, kidneys are a big regulator of water and sodium balance, right? So if you don't have good functioning kidneys, you're gonna have problems with your fluid and electrolyte balance rate. Okay, we talked about renin being released if the kidney sense low blood volume, low blood pressure. Okay. This is another picture if you guys like more of the intense pictorial representation. Some people like it, some people think it's more confusing. Okay, just another picture. All right, let's look at how this can play into practice when we think about some medications that we commonly will give. Okay, we have ACE inhibitors. Let's start there. Okay, ACE inhibitors. So we talked about ACE, angiotensin converting enzyme, right? What did that do? What was the role of that?
It brings angiotensin 1 to angiotensin
Converts
2.
it from angiotensin 1 to 2, and then 2 is the active form. And the active form causes what? Vasoconstriction. Okay, so now we have an ACE inhibitor. Okay. So this is blocking
That
the
conversion.
angiotensin converting enzyme. Okay, so instead of having constriction, we're having a relaxed blood vessel. Okay, who takes these medications?
High blood pressure.
Hypertension, right? Patients who have hypertension. Heart failure can also be given for this one, right? Common medication. How do ACE inhibitors end? What is their ending, their suffix?
Brill.
Prill. Okay, so anytime you see a medication end in a prill, you should know that that is an ACE inhibitor. And then your client says to you, well, you're giving this medication. Oh, how does this medication work? And you're gonna be like, let me get out the rack and I'll show you, right? You don't carry that in your back pocket ever?
Mm.
Yeah. How would you explain this to a patient if saying, well, why am I taking this medication?
Box it, conversion.
Blocks the conversion of what?
Just one, they're not gonna know to be.
That's a lot of words.
What you want to say?
You don't wanna say, oh, just tell your patient. What could you tell them? It relaxes your vessels, right? Right? And cause them to be really tight, and that causes your blood pressure to be really elevated, so it's gonna relax
And hopefully lower your blood
and
pressure.
hopefully lower your blood pressure, okay? All right, blocks ACE, blocks angiotensin 2, also blocks aldosterone. Okay? So, getting rid of sodium, getting rid of water, but what else will it hold on to now?
Potassium.
Potassium, okay? So we need to watch our potassium level when a patient is on a pill, right? Because it's gonna get rid of that sodium and water, again, decrease blood volume, but it's gonna hold on to that potassium. So you need to make sure you monitor that. Common side effect, dry cough. Is it gonna kill you? Is it gonna be annoying? Not common, but what is a adverse effect that can sometimes happen with a prill? Angioedema. Yep, you have to watch for angioedema. All right. ARBs. Angiotensin receptive blockers. How do those end? Sartans. Yep, they end as a sartan. Or not sartan, but it's a losartan. Losartan is a big one, okay? It blocks angiotensin 2, right? So it keeps, again, the blood vessels from narrowing by blocking that angio2 receptor, right? We talked about it causing vasoconstriction, now it's gonna cause vasodilation. Okay. Tends to not give that cough. Okay. Doesn't tend to have that. Again, treating hypertension, heart failure. It will also, again, hold on to potassium, so you need to watch that potassium level, but doesn't tend to have that cough, that kind of irritating dry cough that sometimes can happen. Are you gonna give these medications?
Mhm.
Absolutely. Okay. A lot of medications like this that we're giving for our patients who have high blood pressure. All right. Gerontological considerations, right? We talked about this. Over time, the kidneys might not be able to conserve water as well. Okay, again, at risk for dehydration. Okay, may also have a decrease in renin and aldosterone. Subcutaneous tissue, less muscle, again, thirst. They have that decreased thirst reflex. All those things we just talked about. Okay, let's talk a little bit about spacing, where fluid can shift when it comes to fluid spacing. Okay, first spacing is normal, that's that normal distribution of fluid throughout the body. Second spacing sometimes is just kind of your abnormal, more into your edema. So it goes into the interstitial spaces. So when will you see edema? Okay, you could see heart failure.
Fluid overload.
Okay, fluid overload. What else? Okay, could be liver failure. What if I just sprained my ankle? Could I see some edema that way?
Mm-hmm.
Right, yeah. Okay, so it could be definitely tissue damage, or it could be, fluid shifting, extra fluid shifting into the interstitial spaces. Okay, that top picture there, what do you think? Do we have some pitting edema on that top picture?
Yes.
Yeah, absolutely, right? So you might have patients who have pitting, they might have non-pitting edema. Okay. And then third spacing is fluid trapped where it's difficult or impossible for it to move back into cells or blood vessels. Okay. So this is when it can accumulate in the interstitial spaces. It can actually go into a body cavity, right, where it kind of sits there. What can happen if we have a large amount of fluid that goes into maybe a body cavity, the interstitial space, right? What's happening here? This is not a pregnant female. This is Saïd's, right? We've got fluid that's shifting into the abdominal cavity there. If all this fluid is shifting into the interstitial space, what happens to my vascular space, my blood pressure? You think it could go down? Right? Because now we have fluid that's not within the vascular space, but now is within this third space. And it can cause my blood pressure to maybe go down, right? Therefore, my cardiac output is down, okay? If it's severe enough, right? If it's severe enough. Anybody know what we can do, what medication we can give to draw that fluid back into the vascular space? Albumin, yep, good, albumin. We also might have to give an isotonic IV solution to increase our blood pressure, right? If we have a low blood pressure and a patient isn't able to stabilize, we might have to give an isotonic, it's gonna stay in that vascular space. Or we'll give albumin, which can draw that fluid, uses that osmotic pressure to draw that fluid back into the vascular space. All right. Let's talk about our first imbalance here. We have extracellular fluid imbalance. We're going to talk about hypovolemia or volume deficit, dehydration, right? Kind of all those different terms. Okay. Basically, what it means is fluid intake is less, right? Our fluid intake is less than what is needed to meet the body needs. Okay. So let's think about, how do we lose fluid? Give me an example of how we lose fluid. Vomiting.
Urination.
Urination. Hemorrhaging, like a trauma, hemorrhaging. Okay, those are big ones, right? Vomiting, diarrhea, a trauma, or a hemorrhage. Okay, what else when we not, when our fluid intake or retention is less? That's we're losing fluid. What else? Overuse of diuretics is a good one, right? Think about those medications. What else?
Drinking too much.
Drinking too much or not enough? Not enough. Yep, so not taking in enough, right? We're dehydrated, hypovolemia, so not taking in enough. Do you ever have patients who are NPO? Okay. What if they're NPO for a long extended period of time?
Mm-hmm.
What do you need to do? Check their blood sugars. What else do you need to do? Fluids, right? IV fluids, right? Okay. So there's a variety of ways where we might be not taking in enough, but we might be losing body fluid. Okay. We may not be taking in enough, or there might be a shift. There might be a shift of the fluid. Okay. So like maybe it burns, right? There might be a shift from the vascular space into maybe a different space, interstitial space. Okay. So let's think about a client, somebody you would see who comes in, who is maybe hemorrhaging, right? A severe automobile accident, they have an amputation of their leg and they're bleeding. Okay. What changes in your vital signs are you going to see? Tachycardia. Yep. Low blood pressure, right? We've lost a lot of blood. Our blood volume is lower. Our blood pressure is low. Our heart rate is high. What else happens?
Increased respiration.
Increased respirations. Again, yep. So we're compensating. Okay. What would you feel like neurologically if you lost a lot of blood and a lot of fluid? Dizzy, right? Big dizzy, lightheadedness, absolutely. Okay. Confusion, cardiac, okay? Our heart rate is going up, right? Defined as tachycardia. If I have less blood volume, I'm feeling my pulses. What do they feel like? They're weak. Okay. Respiration rate, we talked about the increase. Kidneys. Decrease urine output, right? We have less blood volume. Okay, if we have less blood volume going on, are the kidneys gonna be like, oh, I should get rid of some?
No.
No, it's gonna hold on, right? Because we have to hold on to as much fluid as we can. Okay. If we do have any urine output, what might it look like? If you're dehydrated and you go to the bathroom and you urinate, what's it look like?
Dark yellow.
Concentrated, yeah. Okay. What would happen to my urine specific gravity? If I was dehydrated?
Elevated.
Be elevated, yeah, it'd be elevated. Okay. What would my skin possibly look like, feel like? Pale. Pale. For skin trigger. Yeah, dry. Okay, good. If I lost blood, like I'm hemorrhaging. Okay. Okay, what would my H&H look like?
Blue.
Right, I've lost it in the blood. What if I'm just dehydrated? Because I've had the stomach bug. And I've been vomiting, diarrhea, dehydrated. What happens to my H&H? Goes up, why?
Because you're not getting rid of fluids.
Right, so what's that called? Hemo concentrated, right? Hemo concentrated, right? I've lost a lot of fluid, but I have all those particles there. Good. Okay, good. All right. Interventions. Okay, so we have to really think about cause. If I'm hemorrhaging, you better what? Stop it. Yeah, let's stop my bleeding. Yep. And then what do I need? Fluids and blood, right? Okay. I need fluid, I need blood. If I'm dehydrated, because I've got a stomach bug, I've got food poisoning, how do I treat that?
Fluids.
Fluids, how? What route?
IV or oral.
I could do oral, I could start with oral, right? If I can tolerate, we want to start with least invasive, we could do oral intake, let's do that. I could do water, but what else could I do?
Pedialyte.
Pedialyte, right? What is Pedialyte? It's got some electrolytes, right? So I get a little electrolytes that I've also lost. Okay, so I could do oral fluids, I could do IV fluids. Okay, what if I have diarrhea? Is there any medications I can do? If I'm nauseous and vomiting. Yeah, antiemetic. Okay. Maybe I have a really severe fever and I'm losing a lot of fluids that way. How can you treat a fever?
Acetaminophen.
Okay, antipyretic, acetaminophen, and NSAID. Yeah. Okay. Let's see, what else? What else causes? Maybe it's a bacterial infection, GI symptoms type of thing. Could you treat it with an antibiotic? Okay, as long as it was a bacterial versus a viral. Okay. Am I at risk for anything if I'm dehydrated? What kind of safety precautions do you have to do for a client who maybe is severely dehydrated? Spouse, okay. Because what can happen? I stand up really, has anybody ever stood up really quick? A little dehydrated, what happens? You get dizzy, orthostatic hypotension, down you go, right? So making sure that our patients are safe that way. Good. All right, let's talk about babies, infants, and what might you see in a child who is dehydrated? Okay, might be a little bit different. Okay, so what do you think about output? Not many wet diapers, right? So a child's gonna be on, an infant is gonna be wearing a diaper, right? So can you as that nurse measure output through a diaper?
Yes.
Yeah, so definitely. So you want to be checking the diapers, right? Measuring the diapers. making sure that they have some urine output. What other mucus membranes look like? Dry. Yep, dry. Don't have to get a little sticky. Cry might be a little bit different. Okay, might be more high pitched, might be more irritable cry. Neurologically, what do you think? Okay, more fussy, more tired, right? More lethargic, not really wanting to do much. Okay, what would be our respiratory rate? Increased, right? What about our fontanelles for a baby? We've got
Sunken.
anterior and we've got posterior.
Sunken.
Sunken in, right? Okay. So when they're dehydrated, they can sink in. When they're overloaded, or might have some ICP, what happens to those fontanelles? They bulge out, right? Okay. So anterior closes about 18 months. Posterior is about 2 to 4 months. Okay. So usually that anterior one is the one you're usually assessing. Okay. What about skin? More tender or dry, it might be cool to the touch, right? Okay. Good. All right. So what are we gonna do? Okay, we talked about doing oral replacement, so we can try that first, giving them water. We can do an oral rehydration solution like a Pedialyte that has water, also has some electrolytes. Sometimes it's severe enough where we have to do IV fluids, okay? Do you guys learn anything about in skills about different types of IV devices? A little bit? Yeah, okay, so short term. So peripheral IV, that's usually used for short term. What kind of things would you put a peripheral IV in for short term use?
Blood transfusion.
Okay, blood transfusions. One-time blood transfusion, what else? IV fluids, antibiotics, short-term antibiotics,
Anesthesia.
okay, anesthesia. Yeah.
Most of the time, any hospital stay.
Any hospital stay, you usually just have one just
Mhm.
because, right? They give any medications, emergency medications. Okay, so they're usually in for a couple days, maybe a week if it's a good one. I have to change it out pretty frequently if they're in the hospital. Okay, what about long-term? Long-term vascular access devices, central lines, peripheral, or PICC lines, ports. Yeah, chemotherapy. What else do we use in long-term?
Chronic conditions.
Chronic conditions like what, for what? Or possibly for heart failure, because what do we maybe have to give frequently? Dialysis, chemotherapy,
Mhm.
okay, long-term antibiotics. A client who has osteomyelitis, right, they're gonna be on a long-term antibiotics, 4 to 6 weeks. So you should put a PICC line in for them, it's long-term, they can have it in long-term. Okay, ports a lot of times for patients who have chemotherapy. Okay, how does the central line, the long-term line differ than the peripheral line?
Goes straight to the heart.
Yeah, where it's placed, right? It's gonna sit in the superior vena cava, right? It's gonna go right to that heart. Okay, so be very careful with your dressing changes, right? Okay. Large amount of fluids. Also need a long-term, like if you have a burn victim who needs a lot of fluids, or TPN, we'll need a central line, okay? All right, so knowing what kind of IV device you have, and then when we think about IV therapy, we can give IV medication or IV fluids either through a short term or a long term, okay? When we're looking at IV fluids, we're gonna look at the normal or the osmolarity. If you look on page 258, in the new book, the new version, it talks about the different osmolarity of common IV solutions. Okay, so the normal osmolarity of blood is about 270 to 300. Okay, that's what the normal amount is. And what did we say the osmolarity was? Osmolality. Sometimes you'll see osmolarity, osmolality. I just use those interchangeably. Okay, what is that telling me? What is that looking at? Concentrated, right? Those particles, right? The amount of solute in there. So 270 to 300 is normal for blood. That's what blood looks like, okay? An isotonic solution, what do you notice about that osmolarity?
It's the same.
It's the same, right? It's the same as blood. What do you notice about a hypertonic solution? It's greater. Okay? The osmolarity is greater, the amount of particle solid that you're getting. What about hypotonic?
Less.
It's less. Good. All right, it is time for our first break. It is 9:10. If you want to come back in. So less than what? What did we say was normal?
270.
300? Okay, so anything less than 270, right? I'm gonna start at 258. Of course, you do not have to memorize the osmolarity, right? Don't spend your time. Right? But just know that the concentration of solids is less. Okay? So what happens with a hypotonic solution? There is a shift of water, right? Where does the water go? Into the cell, right? So think hypo, right? The big O, that means it's going into the cells to plump up those cells. Okay? A common fluid for hypotonic is half normal saline. How would I write that as a decimal?
0.45.
0.45% sodium chloride is half normal saline. Okay, so I'm getting some sodium, I'm getting some chloride. Another one might be 0.33 saline, D5W, again, it starts out isotonic, it goes to hypotonic. Okay, another one that I did, I worked in peds for a long time, and we don't always give our clients half normal or quarter normal saline. And how do you think I'd rate that? 2.255, yeah, I know, it's weird, the fractions. Okay. So it's the osmolarity is less, right? Okay. So we have a shift, the fluid shifts out of the vessels and into the cells, so it's gonna hydrate our cells. Okay, a big one that we'll talk about with our next unit of endocrine is when a patient has DKA or HHS. The patient becomes dehydrated, cellular dehydrated. So these fluids shift into the cells to hydrate those cells. Okay. Again, it can provide free water like your D5W. So let's think about it. If there's a fluid shift from our vascular space into our cells, pumps up those cells, what can happen to those cells? Swell, yeah. And then what happens, especially in my brain?
Edema.
Cerebral edema, right? It can cause increase in the cranial pressure, cerebral edema. So we need to watch, be careful with that. Okay, also, if my fluid is shifting out of my vascular space into my cells, what happens to my vascular space then? I have fluid that's not my vascular space. What happens to my blood pressure? It go down, right? I have less fluid, I have less volume. Okay, so I need to watch for intravascular fluid depletion, which can cause my blood pressure to be up. Okay. Can we use this type of fluid with our blood transfusions?
Mm-mm.
Okay, that's again, it's going to cause hemolysis of those red blood cells. Now you have a transfusion reaction. Okay, hypertonic. The osmolarity is higher than plasma. Okay, so we have a greater concentration of solids than the plasma. Okay, so though it's greater than 300 in our osmolarity. Okay, so you have examples like D5 half normal saline, D5 normal saline, D5 LR. Okay, what do you notice about all those top three?
It's got glucose.
They have glucose, they have dextrose in them. Okay, those all have dextrose. Does that make sense? If I have a lot of dextrose, a lot of sugar, doesn't that make sense that I have a greater concentration of solutes? Because I have all that sugar within that fluid, okay? So where is the fluid going with hypertonic?
Vascular.
Into the vascular space, right? It's shifting out of the cells into the vascular space. So the cells will shrink. Do we think we need to watch for hyperglycemia with these patients?
Yes.
Especially if there's a history of any diabetes, okay? Another one that you might be given is 3% sodium chloride, right? What did we say normal was? Normal sodium.
0.9.
0.9. 3%. Pretty high amount of sodium, right? Who gets that? Who gets 3% sodium chloride? Who needs more sodium? Hyponatremia, right? If I have a patient who has severe hyponatremia, I'm gonna give them 3%. Okay? Those are critical situations. You're not just doing it in the clinic, right? Usually it's gonna be in a critical care setting. Gotta do it really slow, okay? And if fluid is shifting out of the cells into the vascular space, what do I have to watch out for then? Fluid overload again, right? Got too much fluid in the vascular space, it could cause me to go into fluid overload. Okay? So watch for high blood pressure, right? It can even cause pulmonary edema, right? Blood pressure goes up. Patients have a hard time breathing.
So hyperglycemia, hypertension.
Could happen, right, depending on the patient, yes. Yep. So these top ones might be given post-operatively, right? Does that make sense that I would give my client fluids, right, to maintain fluids, because we've got half normal saline, normal saline LR, but also dextrose, right? If my patient isn't eating, don't you think they need a little bit of dextrose also, right? We need a little energy that way, right? So patients might also be on dextrose. You would not give your 3% post-operatively, right? That's your patient who has hyper or hyponatremia. All right, turn to your partner and explain those three fluids. Where's the fluid shifting? What do you need to watch out for?
So
Okay, right? So it's similar to composition of plasma. So it has the water, it has the sodium, it has the chloride, it has the potassium, calcium, and lactate. Okay, which condition is this okay for? Because lactate is converted to bicarb.
metabolic.
Metabolic acidosis. Okay, it's okay for metabolic acidosis. It's not okay for
Lactic
lactic
acidosis.
acidosis, right? Does that make sense? Why would I want to give more lactate if I have lactic acidosis? Okay. All right. Watching your lab values also with this, right? Because I'm also giving calcium, I'm giving potassium. Okay, so watching make sure that those don't become too high. All right, and then this is just another picture. If you can kind of think about hyper, right? Fluid shifts from out of the cells and makes them kind of shrink. Hypo goes into the cell, swells them, pumps them up, they're hydrated. And isotonic, right, is just the same. All right. Colloids, right? So we talked about crystalloids. So crystalloids are considered your IV fluids that we just talked about. Crystalloids meaning that they are semi-permeable membranes and fluid can shift in and out of those cells. Okay. A colloid then These contain molecules that are too large to pass in and out of the membrane, okay? So these colloids are gonna stay in the vascular space, in the intravascular compartment. Okay? These are considered volume expanders, plasma expanders. So we talked about albumin, right? Albumin can hold raw fluid and increase the vascular space, intravascular space. Okay. We can also do blood, we consider that. And then there's also some semi-synthetic, like dextran, Hespan. Those are also maybe out in paramedics, out in the field, military, right? Those medications can be given if a patient was bleeding, the patient had low blood volume to help expand and increase that volume. Because ultimately, what are we trying to do? If we have low blood volume, what do we have along with that? Low blood pressure. And if we have low blood pressure, then we die from that.
Mhm.
Yeah, right? So volume expanders are going to help expand the blood volume, which is going to increase our blood pressure. Okay. So maybe not seeing those as commonly in the hospital setting because we have blood products with IV fluids, right? But maybe more in the field if you work paramedic on military. Okay, so those stay in the vascular space. Crystalloids, that's when they can travel in and out of those cells. Okay. So we talked about fluid volume deficit. Okay, so turn the page on your handout. Right? You have fluid volume overload and fluid volume or fluid underload. So I want you to take 2 minutes and fill in that second row that's underload without looking at your notes. Without looking at your notes, we talked about underload, we talked about dehydration. So the second column, can you fill in those blanks on what you remember? Right, use your brain, think about what you can do. So what would you fill in for underload? Okay. Okay, now talk to your partner. Do you guys have the same answers or something else you need to add to your chart there?
Both. It's elevated with dehydration, but decreased with hemorrhage.
Oh, yeah. Right? Right back? So if it's not hemorrhaging and then it's equal concentration and not.
Yes.
Bing, bing, bing.
All I just remember is hemorrhage, is low, because obviously you're losing blood.
We'll come back to that here when we get done with our overload here. Okay, so our next part is excessive volume, right? Fluid volume excess, hypervolemia, fluid overload, different types of way to say that, overhydration, right? Okay, so we have an excessive amount of body fluid, can be caused from an excessive intake, okay? Or abnormal retention, okay? Or a fluid shift. Okay, so we're talking about these different changes here. So in excessive intake of fluids, right? Like what kind of fluids? Water. Yeah, intravenous. Okay. What about retention of fluids? Abnormal retention of fluids.
Holding onto that
Yeah.
water.
Like what? Yeah, who has that? Who's holding on to extra fluid? Cardiac patients, your heart failure patients, and
Kidney.
kidney, yep, your kidney disorders, right, chronic kidney, okay? It might be other things like, SIADH, we'll talk about that in endocrine. Syndrome of inappropriate antidiuretic hormone, right, they're holding on to extra fluid. Water intoxication. All right. So let's look at what we might expect if a client is taking in too much fluid. What type of neurological changes? Would there be anything that we would need to notice that we might notice? You have fluid overload. What's that? Confusion. Confusion, yep. Might have some changes in their level of consciousness, their confusion. Okay, what about cardiac? What is my heart rate gonna be?
Hello.
I got all this extra blood volume. What's my heart gonna do? It's gonna be harder, be higher and harder, right? Cause I have more volume. I need to pump it through my body. What happens to my heart rate? Or my blood pressure?
Also high.
It's elevated, right? I have more blood volume. If I have more blood volume, my blood pressure is gonna be elevated. Again, has to pump it through. What's my respiration rate gonna be? Higher, right? Again, do I also have to help get that extra fluid through? Breathing more, get all that extra fluid through, okay? What about my pulses? Bounding, easy to palpate, bounding, okay? Kidneys, if my kidneys are functioning, I'm taking in a lot of fluid, what should my kidneys do?
Increased urine output.
I should have more urine output out, right? But what about if I have sick kidneys? Then I might not have any urine output or minimal urine output, right? So it kind of depends. But if I'm drinking a lot, if I drink a lot of water, what should the urine look like?
Clear yellow.
Right, clear, yeah, if it's so diluted, right, it should be clear. Okay, what about the skin? It has some edema, yeah, it might have some edema, it might be pitting, it might be non-pitting. Okay. Yeah, anything else that we need to include?
Weight.
Okay. What about the weight?
Weight gain.
Weight gain, yeah. Also with respiratory, where there might be some changes in our lung sound. Possibly crackles, right? If I have extra fluid in my lungs and I crack those, how might I also feel?
Short of breath.
Okay, that could be something else the patient may experience. Okay. Any lab values that I need to be concerned about or that I might. Okay, what's gonna happen to my H&H? It's gonna decrease, why? Yep, hemodiluted. Okay, hemodiluted. Oh, jugular veins. Right, our neck veins. What might you notice in a patient who is overload? Distended, yeah, jugular vein distension, JVD. This is something we'll talk a little bit about more closely when we get into cardiac. But sometimes a patient who is in heart failure, who's got fluid overload, you might hear an extra heart sound. An S3, right? Normal heart sound is S1, S2, loved up, right? So a patient who's in heart failure, you may also hear that extra S3. What could happen to my other electrolytes? My sodium? If I have fluid overload? If I've got too much fluid, what can happen to my
Low.
electrolytes?
They're all gonna be low.
They could be diluted, right? Other electrolytes could be also diluted, like my sodium, right? If I take in too much fluid, that could also be decreased. All right, so what do I do for a client who is fluid overload? Right, if they're taking in too much water.
Fluid restriction.
Fluid restriction, if I gave them too much IV fluids. Right, sodium restriction, fluid restriction, stop the fluids. How do I get rid of some extra fluid? What medication?
Diuretics.
Okay, diuretics. What are some different classes of diuretics that you learned about?
Loop.
Loop diuretics like furosemide, thiazide diuretics like hydrochlorothiazide, potassium sparing, spironolactone. Okay, so different classes, so make sure you understand those. Okay, so I can stop my IV fluids, I could do a fluid restriction, I could do a sodium restriction, I could do diuretics. Daily weight, we want to check those, absolutely.
Would we want compression socks if they're having?
Yes, if they've got some edema, we can do some compression socks. We definitely want to be doing eyes and nose. Was there any other medication that you could give that would remove fluid? But maybe we're gonna keep and hold on to that sodium, those electrolytes. Okay, Fulvaptan and Fulvaptan, right? Those are your medications that are going to hold on to your electrolytes but get rid of fluid. What are they called? Vasopressor receptor antagonists? If I have a patient who is fluid overloaded, too much fluid, and their sodium is low, right? What's my risk of giving a diuretic?
Lowering that sodium. more.
Yeah, I could possibly lower that sodium more. So I need to be careful that I'm also monitoring their fluids, but I'm also monitoring their electrolytes. Safety, do you think safety is also important?
Mhm.
Right, skin, watching their skin, make sure there's no skin breakdown, repositioning. Looking at their sodium. Okay, and these are some of those labs that we talked about, hemo concentration, hemodilution. Okay. So when like the H&H or electrolytes are high, the client is dry, right? So it's hemoconcentration. Okay. When the labs are low and the blood is liquidy, right? That's hemodilution. Okay. So hemodilution can happen with fluid overload. Hemoconcentration can happen with dehydration. Okay. Does that make sense? Wrap your brain around that one. Right, when I'm dehydrated, I've lost fluids, but those electrolytes, particles are still going to be in my plasma. All right, now fill in the rest of your chart there, right? We did underload. Now I want you to fill in overload. Without looking at your notes, just try to use your brain first, and then I'll have you work with your neighbors.
We didn't talk about urine specific gravity.
We didn't.
I have a question.
Yes,
So concentration, is that osmolarity is high and hemodilution osmolarity low? Okay.
yes, you are correct. Right, so he concentrated, like the blood is very concentrated with those particles. Yeah, your blood osmolarity is high. Yep.
Did you just want to get like constant time?
That's the thing, so usually the first ones that they need to start with that, depending on what the cause is.
Okay.
Again, dehydration from PKA that we'll talk about in endo, you want to give us isotonic and also hypotonic.
Okay.
Yeah, usually ISO with dehydration is pretty common.
Okay.
Yep.
Thank you.
Okay, so a patient who is underloaded, right? A patient who is dehydrated. Vital sign changes, we talked about blood pressure is gonna do what?
Low,
Be low, our heart rate,
up,
up, our respiration rate,
up,
and our pulses.
weak,
Right, our pulses are gonna be hard to find, right? We have less blood volume, harder to find, right? They're weak or hard to find, hard to palpate. What happens to our weight?
decreased or stayed the same.
Decreased or the same? Urine output, if we're underloaded.
Decreased and concentrated yellow. Dark yellow.
Hemoglobin hematocrit,
Increased.
increase.
But
Urine,
you said with hemorrhage, it's
yeah, so
decreased.
hemorrhaging. So a patient who is hemorrhaging.
Yeah.
What's gonna happen to your H and H?
Low.
Goes down, good call. All right, urine specific gravity.
Elevated.
It's increased, yeah. Other lab values.
Possible low electrolytes.
What might happen to our electrolytes if we're underloaded? Less. Are they gonna be increased?
No.
Yep, they'd be increased, it's more concentrated, right? Those electrolytes are more concentrated, we've lost fluid. So like your BUN, creatinine, sodium, right, potassium. Anything else that you put in the other?
The blood osmolarity.
Okay, blood osmolarity, yeah, we just talked about that one. What would that be for, underload?
Low.
It's high, it's high, right? Because we've lost fluid. What we have left is more particles. That's how we're measuring that. Okay, what about our neck veins for somebody who is underloaded? Flat, yep, that might be fine, good. Anything else anybody else put? Okay, overloaded. Fluid volume excess. What happens to our blood pressure?
Elevated,
Elevated heart rate,
elevated,
elevated pulses,
elevated,
bounding, respiration rate,
elevated,
elevated weight,
elevated,
increase,
Increase.
urine output.
increased with working kidneys,
With working kidneys, right? But what happens if we don't have working kidneys?
decreased with
It might
damaged.
be decreased, right? Good. Hemoglobin hematocrit,
Decreased,
decrease.
the hemodilution,
Hemodilution. Urine specific gravity,
decreased,
decrease.
it's diluted.
Other lab values.
Electrolytes are low.
Yep, electrolyte can also be diluted, yep.
BNP would be increased,
BNP,
yes.
BNP for fluid, yep, if it's a heart failure patient, yep, that could be elevated, definitely, good job. Yep, so that BNP, so a patient comes in with a BNP of 900. What do you
Severe
think we're thinking?
heart failure,
Severe heart failure, right? We need to diurese them, okay? Blood osmolarity for this one,
low,
low. And our, Neck veins? Distended, jugular vein distension.
I also put S3 for
An
pulmonary.
S3, extra heart sound, you might see the patient with heart failure, good. Okay? You understand that? You're golden. Okay? All right, hi, Michelle.
Hi, sorry.
No problem. We just finished up the glute hurt. Okay, let's see, what am I gonna do now? Actually, let's get out your case studies that you guys did for today. Okay. I want to review your case study. All right. All right, so you have a 78-year-old who's admitted to the medical unit with a diagnosis of gastroenteritis. Okay, so already right there, what are some things that you looked at in that first sentence? What are some important data there? Okay,
Gastroenteritis,
gastroenteritis.
elderly.
78-year-old, right? Anybody older than 65 is considered elderly, right?
Mhm.
Okay, are they at risk for food and electrolyte imbalances?
Yes.
Okay, all right. So, based on this data, let's look at our vital signs. Kayla, vital signs. What stuck out to you for vital signs that you thought were important?
Oxygen levels in the body.
Okay,
Respirations are increased.
good,
Heart rate's also increased.
okay,
Blood pressure is low. And temperature.
right. So nothing's really abnormal here, right? So that patient, so right away, what are you thinking? Gastroenteritis, what is that, first of all?
GI bug.
Yeah, GI bug, right? Nausea, vomiting, diarrhea. Okay, caused by. What's the most common thing? Isn't it norovirus? Isn't that going around right now?
Yes.
Stay away from me, right? But my husband won't go on a cruise because everybody gets norovirus on the cruise. Dang it. Gonna be fun. Okay, so we have gastroenteritis and now we have a low blood pressure. We have a high heart rate. We have high respiration rate. Okay. Lungs are good. Hyperactive bowel sounds. Client is only oriented to person and they're restless. Does that concern you?
Yes.
Okay. Do we know their baseline?
No.
No, we don't. What could restless tell me? You see somebody who's restless, who just
Pain.
can't sit, could be pain. What else could be? Hypoxia? Does that patient have a little bit of hypoxia?
Yes.
Do they have pain? Maybe, possibly,
Possibly.
right? Okay. Poor skin sugar, right? So some clues here, right? I feel so weak, I can't keep food down. Okay, my blood osmolarity is high at 330. Right? What is that telling me? Dehydration. I didn't put your normals here, but what about my sodium and my potassium?
Elevated.
They're high. They're higher than normal. Why? They could be dehydrated.
Dehydrated.
What is that called? Hemo?
Bulimia. Hypo.
Concentration, yeah.
Hemoconcentration. Hypovolemia.
Okay,
That's
so
the
what fluid imbalance are you suspecting?
hypovolemia.
Fluid
Hypovolemia.
imbalance.
Oh,
Fluid
Underler.
hypovolemia. Yep, hypovolemia or underload. Fluid, yes,
Mhm.
it says fluid. It doesn't say electrolyte, it says fluid. Some of you missed that, right? Yes.
Yeah, that'd be me.
What fluid imbalance?
It did take me a couple minutes to be
So
like,
you gotta read the questions, slow down. Okay. Because they also have hypernatremia and hyperkalemia, right? But what we're thinking hypovolemia, dehydration. Okay? What are the contributing factors?
furosemide,
Okay, they're taking furosemide, which is what kind of medication?
diuretic,
A diuretic? Is it Taylor? Yeah, what else, Taylor? What else is a contributing?
The age, gastroenteritis.
Yep, the age and the gastroenteritis, right? Those are things that are causing that fluid imbalance. Okay, anything else that would contribute?
Unable to keep any food down.
And they're able to keep any food down, right? That kind of goes along with that gastroenteritis, right? They're not able to drink or eat anything. Good, okay. Medications. What's the sign in? I can't remember names yet. Tiffany? Thank you. Tiffany, what do you know about furosemide? Telling you about, the medications here.
Furosemide and loop diuretic.
Okay,
Used to treat fluid, biomethanol.
okay. What are the side effects?
Metabolic alkalosis, toxicity, hypervolemia.
Yep.
Hyperuricemia, hypocalcemia, hypermagnesium.
Okay, so a lot of changes in our electrolytes, right? So furosemide for probably heart failure, blood pressure, right? The client is taking that for, we don't know, we don't have the information, right? Okay. Patients who take furosemide, which is a loop diuretic, they often will lose potassium. Okay, what have you noticed about clients who take furosemide? Do they take anything else along with that?
Usually potassium.
Yeah, a potassium supplement, right? Because their potassium can become too low if they take a loop diuretic. Yes, so they'll often will take a potassium supplement. All right. Is it Amanda?
Yes.
Okay, Amanda, tell me about lisinopril.
It's an angiotensin converting enzyme ACE inhibitor used to manage hypertension by blocking conversion angiotensin 1 to angiotensin 2.
Okay.
It actually reduces the vasoconstriction and lowers blood pressure.
Yep, good. We talked about that already.
It
Good.
increases aldosterone secretion, leading to reduced sodium and water retention while
Good.
increasing the sodium retention in fluids.
Good.
Side effects, hypotension, hyperkalemia, dizziness, persistent dry cough.
Okay.
Rare but serious, include angioedema and acute kidney injury.
So cough and angioedema, right, we talked about. And then the lab values, right? What was something that we need to monitor with that one also? Did you say this one? Maybe you said it. Just
Potassium.
potassium, yeah. So we're
It's
gonna
poses a risk.
poses a risk for it, yeah.
Hypertension.
Yeah. Yep, so we're giving that again for heart failure, blood pressure, decreasing that. Very good. All right, what about duloxetine, Alyssa? Yes,
It is a statin, or sorry, wrong one.
Wrong
It's
one.
SNRI.
yes,
It is used to treat, or help manage depression and anxiety. It can be used for, neuropathic pain or like diabetic pain. It inhibits, serotonin and norepinephrine. I can't ever say this word right. Norepinephrine.
norepinephrine.
Yeah, that.
yeah, good.
Common side effects are nausea, dry mouth, constipation, diarrhea, dizziness, fatigue, insomnia, hypertension. Monitor closely for suicidal tendencies, monitor vital signs. Educate the patient that this should not be taken with alcohol and cannot be stopped.
Okay, good. Good, so SNRI, good. Okay, Nye, what about atorvastatin?
It is a statin, but it is also a HMG CoA reductase inhibitor. It inhibits that CoA, which reduces LDL production. Side effects include diarrhea, heartburn, gas, confusion, UTI. We should continue to monitor those cholesterol levels.
Okay.
Monitor liver function and renal function, and do report any increased muscle weakness.
So for cholesterol, lipid lowering medication, okay? So are any of those contributing then to her possible hypovolemia?
Furosemide.
Furosemide?
Mhm.
All right. What interventions, prescriptions would the nurse anticipate?
Stopping the diuretic.
Um,
Oh, sorry.
yeah.
Kylie, I had to think about it for a second. Sorry.
Stopping the diuretic.
Okay.
Maybe giving IV fluids and then.
Do we, wait, do we want to stop a patient's medication? Because why are they taking a diuretic?
To get rid of fluid,
Okay,
excess fluid.
so do you think we would stop it, like forever?
Maybe
No,
hold it.
Okay. Stop it when?
Probably just until we, for like, hold it for that.
Maybe
day
hold it?
until the-
Yeah, right. Right, we want to hold it until we can get her kind of stable. Yeah, definitely, but, okay, good, what else?
Probably IV fluids or oral fluids.
Okay,
And then putting him on a cardiac monitor.
okay, good. So oral fluids, but I can't keep anything down. Would there be anything you could give before or medication to help?
Zofran.
Maybe antiemetic, maybe ondansetron, maybe she just doesn't want anything, then IV fluids, right? What kind of IV fluids would you think you would give? What class? ISO, hyper, or hypo? For dehydration, what do you think? ISO, yeah, and that would example would be your normal saline, your lactated ringers, right? Those are usually your most common ones. D5W is more for your water replacement. Okay, good. Anything else we would do? Oxygen, yeah, a little oxygen, and that should improve, right? Hopefully our oxygen will improve once we get rid, or once we give her some more fluids. We don't know what her underlying other history is. What else?
Monitor neurological status.
Yes, monitor the neurological status, good. Antidiarrheal. She also has a fever of 101.3. It could be given, yeah, good job, okay. Do you think these are falsely elevated due to being fluid underloaded? Yeah.
Yeah.
But we still want to monitor those, right? We need to give her some fluids and then monitor those again. What happens if our potassium gets too high or too low? Cardiac, right? Think about the heart, okay? So you said monitoring the heart, right? Putting on our cardiac monitor, right? Just to make sure she's doing okay. Good. All right, so we want to give some IV fluids. What's the last one? Teaching plan. Including information about the diet, medications, home care. Let's see, Courtney.
Diet should include increase in fluids.
Okay.
Would we decrease the salt in the diet? Or increase? I put decrease.
Is this, but again, think about, is this elevated due to being underhydrated?
Yeah.
Yeah. So we'd have to look at her underlying. Does she have any heart failure and other problems, right? Why is she taking that furosemide? Okay, but looking at her diet, right, making sure she's got adequate fluids. And what else?
The broad diet.
The bread diet? Someone wrote that.
It's a bland foods, banana, rice, applesauce, and toast.
Okay, yep. So trying to get her to drink oral fluids if you can, and then move on to, easy to digest foods, right? Okay, what else? What kind of education would you provide if this happened again? What would you provide to anybody who has a GI illness like this? Okay, wash hands.
Try and drink.
Try and drink, right? It's important that we try to drink. If you can't do water, maybe electrolyte solution or something like that, correct? Okay. All right, let's go to the other one here. So case study number 2. So you have a client, older client, adult who arrives in the emergency department feeling of my heart feels like it is skipping a beat. All right. Who's up? Taylor. What? Electrolyte balance do you suspect for this client? You said hyperkalemia? Okay. Tell me what helped you find that, decision.
The ECG.
Okay, the ECG was telling me what?
The prolonged interval YQRS and PQT.
Okay. Classic symptoms of hyperkalemia. Good. Okay, anything else that made you think that this client might have hyper? Everybody agree it's hyperkalemia?
Mhm.
Yep.
Substitute.
Okay, salt substitute. So we use that,
Potassium.
but it's high in potassium. Yep, good. Okay, what else?
Many
Also-
of the medications that they're on
Okay.
have side effects of hyperkalemia.
Okay, so we'll talk about the medications here.
His
Okay.
diet
Okay, what about the diet?
is very high in.
Maybe great.
Yeah.
Is it high in potassium?
Yes.
Right, the fish, the potatoes,
Spinach.
spinach, colas, dried fruit, all of that is high in potassium. Okay, so good, yes, I agree, it is hyperkalemia. Okay, contributing factors we just talked about, medications then. Here we have Austin, tell me about spironolactone.
Potassium sparing diuretic. Blocks aldosterone receptors in the kidneys to increase sodium excretion. Side effects are dizziness, nausea, vomiting, diarrhea. Abdominal pain.
Okay.
But for teachings, just to take as directed, avoid salt substitutes on it. Monitor urine output.
Good. And they just started taking this, right? 2 months from now, right? So just started taking it. All right, enalapril is what class of medication? Cura, does it right? Does it right?
Yes, sorry.
Yeah, ACE inhibitor. We talked about that already, right? Anything you want to add to that one about when it comes to hyperkalemia? Are they at risk for hyperkalemia taking this medication?
Yes.
Yeah, remember how that one gonna hold on to more potassium? Okay, tell us about levothyroxine, Mackenzie.
Thyroid replacement or supplements of the T4. Side effects, angina, tachycardia, abdominal cramps, weight loss, headache, irritability. Nursing things, assess the apical pulse and blood pressure prior to administration. And monitor thyroid.
Good. So taking it for hypothyroidism, right? Yep, okay. And then we have metformin. Okay, no. Where are you on here?
I don't think it means.
You didn't mean to, that's why. Marissa,
Well, like Peter, like, morning is for, diabetics, it can cause, severe diarrhea,
Mhm.
vomiting. We want to teach them to be aware of their fluid status.
yeah, good. Just winging it, you guys, it's just doing good, right? Doesn't have her computer on. Okay, so we're in oral anti-diabetic, right?
Yeah.
So patient who has diabetes, so we're trying to control it with medication, right? Okay, good. All right. ECG changes for hyperkalemia.
Tall.
Tall peak T waves, yep, what else? YQRS
For a long period.
for a long PR interval, yep. And then flat or absent P waves, okay, so pretty common what she has right there, right? Okay, interventions, prescriptions you would anticipate. Where are we at? Logan,
Well, the spironolactone should be discontinued or adjusted.
okay,
Then maybe calcium gluconate to help level out some of that, it should be anticipated to stabilize the cardiac membrane.
okay,
Help with the QRSs, PR intervals, P waves.
okay,
And then I'm just reassessing most of, I can't even say it right, the second.
enalapril,
Yes,
what about it?
I just reassess it and adjust the dosage because one of the one of the side effects is hypoglycemia.
Right, okay. So we gotta figure out our potassium. Our potassium is high, right? And like you said, we gotta protect that heart, right? So cardiac monitoring, we're gonna be on. If it's severe enough where the potassium is 6.5, right? We need to do something quick to get that potassium down. Because we can go into a lethal cardiac arrhythmia and the patient can die, right? And we don't want that to happen. What were some ways that you learned about to get that potassium down quickly? Okay, we can do insulin, right? Insulin shifts that potassium back into the cells. So we give some dextrose, we give some insulin. What else? Okay, diuretics. Yep, we can do diuretics. Like what kind? Diuretics. Yep. Sydney?
Yeah, I think those are really-
IV calcium gluconate. Yep, you said that too, right? Protects that heart. Good. What else? Albuterol, right? An albuterol nebulizer is a fast-acting medication, confused nebulizer that can, again, shift that potassium back into the cell. Good. And what else did we talk about? What else? Say it again. Potassium binders, right? Are those gonna work right away? No,
Mm-mm.
they're gonna take a little bit longer, right? Sodium polycisterine sulfate is one of those. Patient takes it. How do they excrete the potassium? How do we get rid of that potassium? It binds, and how do we get rid of it? Which route? The stool, yeah, the stool. And then the book talked about another one. What was it called? Catamere? Okay, I'm not familiar with that one. It has to be a newer one, right? Again, binds, holds on to that potassium, but it's not gonna work quickly. If it's severe enough, the patient might have to have dialysis, right? And get rid of that potassium. We don't want that patient to go into a lethal arrhythmia. All right. What else? Teaching plan. Why do you think that patient is on spironolactone versus furosemide?
The potassium sparing.
It's potassium sparing, so possibly why would they be put on a potassium sparing?
I have hypokalemia.
Maybe they were having problems with hypokalemia, right? They were on furosemide. It was getting rid of extra fluid, but now we were also losing their potassium. So we switched it to a spironolactone, right? Which is fine, but what about that diet? Do you think we need to do some education on that diet?
Yes, less leafy greens, root veggies,
Right?
tree
Who are you
fruits.
gonna get involved?
Dietitian.
Dietary, let's get dietary in here, dietitian. Here's some foods high in potassium, here's some foods low in potassium, right? That's a really high potassium diet. Okay, so we need to avoid taking in too much. Potassium is good, we need potassium, but not everything you eat should be high in potassium. Okay? Good, questions on that one? All right, let's take a break. It is 10:20. I'll see you back at 10:30. Good job. Draining wounds is admitted with hypovolemia. What would be the most accurate way for the nurse to evaluate fluid balance?
Daily weight.
Daily weights. Yep, daily weights are gonna be your best indicator. Very good. Okay, a client who was prescribed furosemide, which is what medication?
Diuretic.
What kind?
Loop.
A loop diuretic for treatment of hypertension, reports weakness. Which action is appropriate for the nurse to take? B. Okay, ask the client about loose stools.
D.
D. Suggest a provider. Did I change the wording? Does it still say suggest?
Suggest that
Okay,
the provider.
suggest the provider prescribes a basic metabolic panel.
I would say D.
D. B.
Advocate for your client.
Okay, advocate for your client because what are you trying to figure out?
What's the cause?
What is the cause? Okay, if a client is taking furosemide, what would be a side effect? Hypo what? Hypokalemia? Yep. What else?
Hyponatremia.
Hyponatremia. Right? Do we need to monitor for those? Dehydration?
Yes.
Okay. How do we know what their sodium, potassium level is?
Metabolic panel.
Yeah, we have to do a metabolic panel, right? We need to assess, right? We need to get that data, find out what's going on with my client. Like I said, what is a client usually on if they're on a loop diuretic? There's also a potassium supplement, right? Because we want to make sure that that potassium stays within normal limits. All right, so that's D. Which of the following patients would the RN delegate to the licensed practical nurse?
D.
D, I heard D? Yes, agree? Okay, why did you pick that one?
Cause it's
Their daily dose.
a med they've already had.
Okay, and that they've already had, they have a history of it, and they take it daily. Is that client stable?
Yes.
Yes, LPNs take stable clients. Okay, what about what about letter C?
Can't provide-
Can't teach, right? They can reinforce teaching,
They can't
Right.
do it.
can't do the initial teaching. Okay, what about B?
It's a new med.
New order. Okay, Conivectin. Think I was gonna trip over it?
Yeah, I don't.
Yeah, thank you. You know it will. Conivectin is what? Yep, vasopressor receptor antagonist. So what does that do? What does that class of medication do? What's it gonna do? It's gonna get rid of fluid, but not electrolytes, right? It's gonna get rid of water, okay? And then A.
Not stable.
Yeah, palpitations, high potassium, are they stable?
Nope.
No, so LPNs will not take an unstable client. They take stable clients, they gather data, they reinforce teaching. That is the role of the LPN. All right, a client with new onset confusion and hypokalemia is being admitted. What are you gonna do about making room assignments?
B,
B, close to the nurse's station, why?
confusion.
Confusion, yes, they're confusion, they're at risk for falls. We need to keep our patients safe. What are some causes of hyponatremia?
Diuretic.
Diuretic use, good.
Low sodium diet.
Low sodium diet, good. Age. So we could not take enough sodium in, or we could lose sodium, or we could take in too much water. Too much water and dilute that sodium out, right? Patient who has heart failure, patient who has fluid overload. Are they at risk for hyponatremia? Okay. Water intoxication, right? Taking in too much fluid. What are some signs and symptoms of hypo and hypernatremia? My little mantra. Seizure.
Coma,
Yep.
death.
Seizure, coma, death, right? We need to definitely, it has a strain on the brain. So we need to monitor cognition, okay? Changes in level of consciousness. All right, 5. A client is receiving diuretic therapy that has a serum potassium of 3. The nurse should alert the care provider for which medication?
C,
D, C, D. Okay, so why are we worried about Glargine and potassium?
It decreases potassium.
What kind of potassium do we use to decrease potassium? Let's talk about that one.
Kinda
What is it
insulin.
for?
we use rapid
We
acting.
use IV regular insulin. IV regular insulin. Glargine is what type of insulin?
Long acting.
It's long acting. Okay, so if you need to get that potassium down quickly, IV regular insulin. Okay. So that one's okay. That was a trick. That was a trick. We're learning a new concept here. The concept was not clear. Okay, so now we know D is not the correct answer.
C,
See,
C, metoprolol, tell me about that. Why would you be worried about that one?
hypokalemia and metoprolol both lower blood pressure.
Okay. But are we talking about potassium?
No, not
well.
Metoprolol is what kind of class of medication?
beta blocker.
Beta blocker, okay.
Slow everything at the heart, and potassium's already low.
Okay. But we don't know what the heart rate is. Do we? Okay, we're getting there.
Is it the
We're
other
getting
heart
there.
bed?
It's
I had that
digoxin.
first.
It is digoxin. Tell me about digoxin. What kind of medication is it? Slows the heart down, but makes it pumps more efficiently. Okay? What happens if I give digoxin with a low potassium level?
Super duper slow.
We are gonna go into dig toxicity. Okay? What happens when a patient has dig toxicity? What's some changes that can happen? What happens to their heart rate?
Seeing stars.
Seeing stars, what happens to their heart rate? Drops,
Very low.
bradycardia. Seeing stars, I don't know if they're seeing stars, but sometimes a halo, and they're a color, like a greenish yellowish halo. Okay, so they have some vision changes. Yep. They also have some GI changes, nausea, vomiting. Okay. So heart, GI system, vision. Okay, we don't want our patient to have a heart rate of 20, do we?
Mm,
Absolutely. Absolutely not.
please no.
Okay, number 6. Client's been hospitalized for 2 days. They're getting normal saline at 100. They have an NG tube set at intermittent suction and their NPO. With priority for the nurse to report to the healthcare provider.
See,
C, yeah, good. Why C? Why is that priority? Airway breathing circulation, and also we have to think about any changes of level of consciousness.
worried about that.
We need to assess further, right? Okay, we need to look at their sodium level, we need to look at their electrolyte levels, right? Anytime you have a change in level of consciousness, you need to get that further investigated, right? Is there a change in their sodium? All right, hydrochlorothiazide is what kind of medication? Number 7. What kind of diuretic?
Thiazide.
Thiazide diuretic, anorexia fatigue. Which electrolyte imbalance would you suspect?
E.
Your D, as a dog?
Mm-hmm.
Correct. Hypokalemia.
Is it potassium leaching?
It is not a potassium waste.
It's not.
No. It holds on to calcium.
Okay.
Yep. So it gets rid of potassium, gets rid of sodium, but it can hold on to calcium. Yep, so you need to watch your calcium level with a thiazide diuretic. Okay. All right, 8. Patients getting potassium chloride IV. Which actions would you take when giving IV potassium? Can you add an A to the prescribed dose of the IV bag?
No.
No. Pharmacy would do that. You would never add potassium to a bag. How about B, giving it through an IV or through gravity?
No.
No.
Never. Never through gravity. It's always on a pump. What about C?
No.
Would you give it IM?
No.
Never. Would I need to monitor fluid intake and output?
Yes.
Okay. Why?
Monitor.
What is coming out? Because if I give a lot of potassium and my patient doesn't pee, guess what? Hyperkalemia, right? So you need to make sure you have good urine output before you give potassium, or else you're gonna put your patient into cardiac arrest. Okay? Should I ever give it IV push?
No.
Okay? Should I infuse it at a rate of 10 milliequivalents per hour per an IV pump?
Yes.
Is that safe? Yes. So D, F, yes? All right, delegation to the UAP, your Universal Assisted Personnel. Which of those can you safely delegate?
C.
C. Can they assist clients for ambulation?
Yes.
Can they assist the client to pick foods?
No.
It's teaching.
That's education and teaching. How about demonstration, how to use a albuterol inhaler?
No.
Okay, teaching. Obtain a urine specimen.
No.
Not for the cat.
That's considered a sterile technique,
Mhm.
so they would not be able to do that. Right, they can do I's and O's, ADLs, right? All right, good job. Questions on that? All right, let's just, I know you guys watched the videos, so let's just talk a little bit about a couple things I want to point out here, right? We talked about hypernatremia, right? Too much salt. We take in too much salt. We don't take in enough water, right? We're dehydrated, but what we have left is our solid there. Okay, or we lose water. Lose excess water, okay? What would be a hypertonic solution that could cause hypernatremia?
3% on the.
Yeah, 3% normal saline, right? We said we can give 3%. We said we could give 3% normal saline for a client who has what?
Hypo.
Hyponatremia. Okay, if I give a hypertonic solution, where's the fluid shifting?
Oh.
Out of the cell
Out.
into the intravascular space. Okay, what am I at risk for? Overload, yep. Overload. Good. Okay, so those are some causes of sodium, right? What are you gonna do about it? Let's go back and think about it. If I have too much salt ingestion,
Limit salt.
limit the salt. Stop hypertonic solutions. Okay, if I'm not taking in enough water,
Increase.
drink more, right? Can you stop breathing, sweating, vomiting, diarrhea?
No.
Please don't stop your breathing, right? So you don't have to stop the patient's breathing. Okay, but what if they're breathing faster because they have a fever? Can you treat the fever?
Yep.
Okay, what happens if they have vomiting or diarrhea? Can you treat that?
Yes.
The patient can the patient have hypervolemia with hypernatremia? Can the client have hypovolemia with hypernatremia?
Mhm.
Yes.
They have either one of those, depending on the cause? Do you know what you would look for in a patient who has hypervolemia and hypovolemia? Signs and symptoms? You should say yes.
Yes.
Yes, I just
Yes,
asked about it. It's on that chart
absolutely.
we went through. Yes, thank you. Okay. Remember with salt, sodium, strain on the brain, right? A lot of has to do with changes with cognition.
Seizure, coma, death.
Seizure, coma, death, right? Hyponatremia, right? Diuretics is a big one. A lot of our older clients are on diuretics, okay, are not taking in enough. Heart failure, dilution. Okay. Changes in level of consciousness, changes in cognition, okay, strain on the brain. If it's from a diuretic, what might need to do?
Or hold the diuretic.
That hold the diuretic? Give them what? If they have a loss of sodium, what can I give them to replace that sodium?
3% no.
So you give 3%, or I can maybe just give a normal saline, right? That has sodium in it. Okay,
Depends on
so
severity.
replacing it, depending on how severe the sodium is, you need to replace that. What if I'm giving a hypotonic solution? Did I stop that? This hypotonic does what? Where does the
Pulls
fluid
the
shift?
fluid into the cells.
Into the cells, right?
Makes them big.
Strain on the brain. Vasopressin receptor antagonists, we talked about those, right? Are those gonna get rid of what? What are we getting rid of? Fluid.
Fluid,
The
but.
water, holding on to our electrolyte, yep, good. Okay, potassium, the big thing you have to think about with potassium is the heart. Right? Know your sources of your electrolytes. Salt, where do we get our salt from? Do we all get plenty of salt probably during the day?
Yes.
Right? And all of our processed food has salt in it, all the good stuff has salt in it, right? So we're usually pretty good about getting our salt intake. Okay, potassium. Right, so think about potassium, not feet. Meat. I meant to say fish and meat, not. Veggies, right? Potatoes, good ones. Bananas, right? We all know the bananas, spinach. Okay? Regulated by the kidneys. What happens when our potassium is high? Cardiac, right? Think cardiac when it comes to potassium. We're gonna have peaked T waves, flat or inverted T waves, and wide QRS. So if we ever have a patient who has hypokalemia or hyperkalemia, what should we have them on?
Telemetry.
Telemetry, right? We need to have the cardiac monitoring. We need to monitor that first. Okay? We talked about how to get rid of a high potassium if we need to do it quickly, right? Diuretics. Calcium gluconate. What kind of insulin?
Regular.
Regular IV insulin. Albuterol. Okay. Those are gonna happen quick. What's gonna take a little bit longer for potassium to be excreted? Yeah, your potassium binders, like your sodium polystyrene sulfonate. Right, those are gonna remove potassium, it's just not gonna happen quickly. Okay, remember insulin, regular insulin, albuterol, right? It shifts that potassium in the blood into the cell. That's where most of that potassium is kept, right, is in that cell. Knowing how to treat a high potassium level. What happens if our potassium is low? What changes are you gonna notice here with hypokalemia? Yep. ST depression, we might see a prominent U wave, which usually you don't see it very often here, okay? Slightly prolonged PR interval. So again, it could give you a thought that, oh, that seems a little low, okay? Do you need to memorize your lab values? No. Okay, remember your normals will be given to you, okay? All right, so how am I gonna treat low potassium?
Potassium.
Potassium, such as foods
Foods.
or supplements. And we get IV supplements.
Yes.
Okay, we talked about that, right? We're gonna dilute it. We're gonna push it,
Mm-mm.
IV push,
Never.
never as a bolus, right?
Never gravity.
Never gravity. You're gonna put it on pump. What else are you gonna check before you get potassium? Urine output, right? We wanna make sure that we have good urine output. What is a normal urine output per hour for an adult?
30.
30, at least 30, right? Okay, good. All right, calcium, bones and teeth and clotting, okay? Again, we get a lot of our calcium from foods, right? Think about your dairy products. We also could get it from broccoli, salmon, kale, right? All those good things. Regulated by parathyroid hormone. We'll talk about this again in endocrine. You guys got a leg up on endocrine already, right? Okay, so what happens if the calcium levels are too low in the blood? Parathyroid hormone is released, and where do we get the calcium from? From the bones, right? Intestines hold on to it, and it's reabsorbed from the urine, right? We want it to be normal, right? If our calcium levels become too high, calcitonin, the thyroid releases calcitonin, which puts that calcium back into the bones. Okay. Not as much as is brought up by the intestines and then excreted through the urine. So understanding how that works. So causes of hypercalcemia, right? Hyperparathyroidism is a big one. We talked about thiazide diuretics, right? What was the example of thiazide that we talked about? Hydrochlorothiazide, right? Like hydrochlorothiazide is going to hold on to that. Signs and symptoms. So what are we going to do if we have it that's too high? We want to get rid of it. Okay, so we can use a loop diuretic. Get that extra calcium out of the blood. Okay, we can hydrate. Where does that calcium deposit sometimes go? From the kidney stones, stones, correct? Okay, so sometimes that extra calcium can deposit in the kidney, so we want to flush it out. So lots of good fluids to flush it out, normal saline. Bisphosphonates. Okay, those medications, you know how those medications end? They have an ending of dronate. Alendronate, yep, so those are bisphosphonates. What do? Yeah, they put calcium in the bones, right? They interfere with those osteoclasts that kind of break down the bone, right? They prevent that bone from breaking down, keeps that calcium in the bones. Okay? What's some important things that you have to worry about when giving this medication? How do you safely give it? Yeah, you have to sit up for, I think it's 32 an hour, sit up upright. Yeah, because it can cause esophagitis. How do you take it? With what? Full glass of water, plain old water. Okay. What do you think with that? All right. Hypocalcemia then, right? Not taking it enough. Hyperphosphatemia. What is the correlation between calcium and phosphorus? They're opposite of each other. If the calcium is high, what's low? Phosphorus is low. If the phosphorus is high, calcium is low. Okay. So some things that you might see when a patient has hypocalcemia, Trousseau's, Chevacek's, right? Those are positive for a client who has low calcium levels. Tingling around the hands and the mouth, muscle spasms. How do we treat a low calcium? We can give calcium, right? Oral IV. Phosphate, there wasn't much in the book about phosphates, right? But we just talked about that, right? If phosphate is high, calcium is low. Do you know what the signs and symptoms of a low calcium are?
Yep.
Do you know how to treat low calcium? Okay. All right, and the last one I just want to touch briefly on is magnesium then. Okay. High magnesium, obviously if you take in too much magnesium, and that should say renal insufficiency, not renal. Okay. Taking in too much magnesium IV. There's some antacid, there's some laxatives, milk of magnesia, right? That are full of magnesium that a patient could have. Let me take in. So how do we treat it? We can treat it with diuretics, IV fluids, furosemide to help to kind of get rid of that extra magnesium. And then low magnesium, a lot of times this could be in your patients who have chronic alcoholism. Low levels of that magnesium. So you want to replace that, right? Replace it with magnesium, right? Okay, so this is all recorded. I just want to point out a few things to you. Okay, all right, you have some questions also in your handouts. Let's go through those. Any class activities? A client is diagnosed with heart disease is scheduled to receive a daily dose of furosemide. Which serum potassium level will the nurse report to the healthcare provider?
Where is this?
It's under like,
The student activities, it's under graded class.
Okay.
So which of those would you report to the healthcare provider? D, right? Furosemide, you're gonna lose your electrolytes. Is that low?
Yes.
All right, a nurse is caring for a client experiencing hyponatremia. Which assessment finding will alert the nurse to a worsening of the client's condition?
C.
C is correct, right? Lethargy and decreased level of consciousness.
Seizure, coma, death.
Seizure, coma, death. Yep, very good. Okay. The nurse, or which client symptoms would alert the nurse to request a prescription to reassess the sodium level?
D.
D, again, okay? changes in cognition, strain on the brain, so any decreased level of consciousness. All right, client diagnosis for renal failure has an arterial blood gas level of 7.29. Which lab result would the nurse expect? So we haven't talked about this yet, but maybe you've talked about it or know a little bit about it. See, yep. So when a patient has acidosis, which that patient does, what happens to the potassium level? It goes up. Okay, if a patient has alkalosis, the pH level is high, what happens to the potassium?
Low.
Goes down. Okay, good. So acidosis at risk for hyperkalemia or high potassium. Good. All right, the nurse is caring for a client with acute decompensated heart failure. Which prescription should the nurse question? What type of question is this? It's a negative step, so we're looking for the wrong answer. Good. We'll read through those.
D.
So the client who has heart failure, are they overloaded or underloaded? Overloaded. Okay, so which of these will we probably not do because we can cause further harm?
B.
Right, give me normal saline at 500, so we're getting 1/2 liter of fluid. Is that patient already overloaded?
Yes.
Yes, we don't want to give them any more. Furosemide, would that make sense to give?
Yes.
Would, oxygen possibly, if
Yes.
the patient's having some issues there, and then potassium, right, especially if we're gonna give a diuretic. All right. When caring for the following clients, which client should the nurse monitor for signs of fluid volume deficit? I heard A. Anybody agree?
Yeah.
Disagree? Who's at risk for a deficit?
B.
I was thinking C.
Yeah, because kidney function.
Kidney failure, what happens when a patient has acute kidney failure?
Oh, they want-
They hold on.
Okay.
They hold on to it. Congestive heart failure?
They hold.
Overload? That doesn't really have anything to do with it. So ileostomy,
Okay.
what happens when a patient has ileostomy? What kind of stools do they have?
Liquid.
They're they're watery, they're frequent, they're looser, so they're at risk for a deficit of fluid. Good job. All right, the nurse is caring for a client who has a decreased magnesium level. What will the nurse assess?
B. B. Those who have low magnesium are usually.
Who has a decreased magnesium, what will the nurse assess? Oh, that's decreased. Who's at risk for a decreased magnesium level? Alcohol use, yeah, alcohol use. Yeah.
Which one's a laxatives? Is that high?
They can have, yep, they can,
With high-
yep, increase it, yeah, it would increase it. Yep. All right, good. The nurse is administering 3% saline solution to a client with severe hyponatremia. What is the most important nursing observation? I heard C, agree, disagree.
Airway breathing system.
Airway breathing circulation, right? Is that a problem? Why could possibly the patient have increased respiratory rate and shortness of breath? Overload, okay? So it's what type of solution? Hypertonic. Fluid is drawn into the vascular space, right? Okay, good job. All right, well, monitoring the client who has fluid volume overload, most concerned about
D.
Airway breathing, got a breathing problem?
Yes.
You could have some crackles. Okay, so it might lead to pulmonary edema, so we have to make sure that we're safe there, so D crackles. All right, client's been having frequent liquid diarrhea for the last 24 hours. The nurse should monitor the client for which electrolyte imbalance?
A.
Diarrhea, yep, A actually, yep, potassium, gotta watch for your potassium with this tool. All right, the student nurse knows the most reliable index of volume status when caring for a client is
D.
daily weights, right? That's gonna be your best indicator. Good job. Good job. All right. And I want to shift gears just for a little bit. We need to look at ABGs, okay? Because your next unit is arterial blood gases, but your assignment, you have to be able to interpret, okay? How many of you have done interpretation of ABG? Someone? Okay.
No.
Are you a master?
Oh, God.
Okay,
No.
see what you got here. Okay, your next assignment has to do with ABG, so I want to do an exercise here. So the first step you have to do is you have to interpret, right? That's the first step. And then you're going to figure out treatment. So just a few things when we're thinking about ABG, right? Arterial blood gases, acid-base balance, right? We have to look at the pH. And the pH stands for what? What does pH stand for? Anybody know? pH stands for the power of hydrogen. So basically, we're looking at hydrogen ions. Okay? So a normal pH is 7.35 to 7.45. That's kind of in the middle there of that sheet that I just gave you, right? Okay? So our blood level needs to be between 7.35 and 7.45. Anything higher, anything lower is going to cause issues, right? So our body wants to stay within that level. Okay? So that is our pH. If a pH is low, meaning less than 7.35, it's acidic, more acidic. If anything is greater than 7.45, it's more alkalosis, more basic. Okay? So, when we are interpreting these, what you have to think about is our normal pH, right? Our PaCO2, what is CO2? Carbon dioxide, okay? Our CaO2 has to do with our acids, okay? Our bicarbonate, our HCO3, has to do with our base and our bicarbonate, okay? So the most common base that you'll see in the body is bicarbonate. The most common acid you're gonna see in the body is carbonic acid. Okay, when you add carbonic acid and water, CO2 is one of the products of it. Okay, so that's why CO2 has to do with respiratory or acids, right? Bicarbonate has to do with the metabolic system or our bases. Okay, we'll talk about this more next week, but I just want to at least get us started here. Okay. Another thing to remember, the more hydrogen ions you have, the more CO2 you have, what happens to my pH? It goes more acidic. Okay. The less hydrogen ions I have, the less CO2 is, what does my pH do? It goes up. Okay? So that's something that you kind of think about too as you're going through and reading through this chapter. Okay? The lungs control the CO2. What controls the bicarbonate, the HCO3? The kidneys. Okay? So when you are looking at these, the first step I need you to do is just figure out how to interpret these. Okay? Step one is that you have to look at each of the values, figure out if they're elevated, decreased, or normal. Use arrows. So I like to use the arrow method. Okay, you have your normals in the middle there. Okay, so let's just do number one. Put your arrows up or down. Okay, so do number one. Let's just go through and just do number one. Is it high? Is it low? Or is it normal? All right, so pH of 7.28.
Low.
Is that high or low?
Low.
Low, right? It is lower than our normal to 7.35. What about our CO2?
Normal.
Normal.
It's normal. What is a normal CO2?
35 to 40.
35 to 45. Our bicarbonate is
Low.
18. It's lower than normal. Okay, normal is what?
21.
21 to 28. Okay? So we are gonna look at our pH first. So if my pH is low, what do I know about a low pH?
Acidosis.
It's acidic. Okay? Now I have to figure out, is it a respiratory problem? Is it a metabolic problem? Okay?
Metabolic.
So respiratory, you can use the term Rome. Respiratory is opposite. Metabolic is equal, meaning are the arrows going opposite directions or the same direction? Are your yes, are your arrows the same or opposite?
Same.
They're same. So is it a metabolic problem
Metabolic.
or a respiratory?
Metabolic.
It's a metabolic problem. Okay. Now you have to go to the next section. Determine if the client is compensating. We'll talk about this more later, but what does compensation mean?
Is the body.
Is the body trying to do what? What is the main goal of compensation?
Equalize.
We want our pH to go back to normal. Okay, so now you can look at the direction. You have uncompensated, partial, or fully. So read through those. Which of those follows compensation?
Uncompensated.
Uncompensated. pH and one other value are outside the expected range. Do I have one normal? As long as I have one normal, it's uncompensated. Okay? Do number two. So number two, my pH is 7.48. Is that high, low, or normal?
High.
32 is my CO2.
Low.
My bicarb is 26.
Normal.
Okay, so based on a high pH, we have alkalosis. Now, how do I figure out, is it a metabolic problem or a respiratory problem?
Are they going the same?
Are they opposite or are the arrows equal? They're opposite, so it is
Respiratory.
it's a respiratory problem.
And there's only
And
two.
do I have one value that's normal?
Yes.
Okay, so that's considered
Uncompensated.
uncompensated. Uncompensated respiratory alkalosis, how you would write that out. Am I lost you yet? You good?
Good.
Okay, do number 3.
Marker's dying.
All right, so 7.56. Elevated, higher than normal. 38 for our CO2.
Normal.
Normal. 33 for our bicarb.
Elevated.
Elevated. Do I have acidosis or alkalosis?
Alkalosis.
Alkalosis. I have arrows that are going the same way.
Uncompensated.
It's a metabolic problem. And I have a normal CO2.
Uncompensated.
Uncompensated metabolic alkalosis. All right, do number 4. All right, 7.31, higher or low or normal?
Low.
Okay, 55 for CO2,
High.
34 for bicarb.
High.
Okay, is it alkalosis or acidosis?
Acidosis.
Is it a metabolic problem or is it a respiratory problem?
Respiratory.
How did you figure that out?
Opposite arrows.
Opposite, right? We always look at the pH first, right? Is there anything that's equal to a down arrow? Nope, so we know it's a respiratory problem because our arrows are opposite. Now, our bicarb is elevated. So now if we look at our compensation, all 3 values are outside of the expected range, or all 3 are abnormal.
Partial compensated.
Partial compensation. What does that mean? If I have a respiratory problem,
The kidneys are kind of.
kidneys are starting to compensate. The kidneys are saying, oh, I see you have a respiratory problem. I need to help. Because I need to help you with that pH level and get that pH level back up to normal. Okay, so partially compensated respiratory acidosis. All right, do number 5.